Module 5, Respiratory. This recording will cover Chapter 26, Coordinating Care for Patients with Lower Airway Disorders. So here we are, our lower airway. So these are the structures. So we have our larynx and down. So we have our trachea, our bronchioles, our alveoli, our lungs, and our diaphragm. So lower airway disorders negatively impact our oxygenation, our ventilation, and our gas exchange. So remember, at the alveolar level is where gas exchange happens. Ventilation is us breathing in and out. And oxygenation, of course, is having adequate oxygen come in and getting picked up by our blood. So lower airway disorders are going to affect this. Our first lower airway disorder is asthma. So asthma is very common in this country. There are over 18 million people here that have asthma. And of that 18 million, 6 million of those are children. In adults, it's more common in women than men, and in children, it's more common in boys than girls. All right, so what's happening with asthma? So asthma is affecting the bronchial airways, not the alveoli. And it ends up with an airway obstruction and bronchial hyperresponsiveness. So what that means is there's constriction, contraction of those small airways, there's inflammation, and it is easily triggered to occur with inhaled irritants. So for a person that doesn't have asthma, if you walk by a building and maybe they're doing construction and you happen to inhale some of that dust, it won't really affect you. You kind of clear your throat and you'll be fine. A person with asthma, that same irritant will cause this hyper-responsiveness, and then it'll cause the tightening of those smooth muscles. It'll cause inflammation and mucus production, and then you have an obstruction in your airway. Okay, so that is asthma. So asthma is intermittent, so that means it's not all the time. It comes and goes. You have flare-ups. It is reversible. So once you start it, you can stop it and reverse it. There's tightening of muscles around the surrounding airways, leads to airway obstruction and bronchial hyperresponsiveness. Type 1 hypersensitivity. Okay, so here's the pathway. You're going to get exposure to the trigger. That's going to trigger the inflammatory response. We already know that vasodilation and then increased capillary permeability is going to happen from that inflammatory response. It's going to lead to airway edema, mucus production, and that airway thickening and bronchial hyperresponsiveness. Okay, so don't move on from this slide until you know exactly what asthma is. All right, so here are some triggers. Irritants could be almost anything. Cigarette smoke, mold, pollen, dust, animal dander, pollution, exercise, pollen, bugs in the home, cold air, exercise, all kinds of things. Anger, okay, stress. Then we have our risk factors. So risk factors for asthma include family history, if you have frequent respiratory infections, eczema, and allergies that cause rhinitis is also a risk factor for asthma. So there is a link between eczema and asthma, but there's still studies and research being done on that, so nothing is confirmed. But a lot of people who have eczema also have asthma and vice versa. Many kids that have eczema will go on to develop asthma. Signs and symptoms. So after a person is exposed to a trigger, the patient will have signs and symptoms like wheezing, dyspnea, which is shortness of breath, coughing, increased sputum. They'll have an increased respiratory rate. They can experience agitation and anxiety. That is a result of hypoxia. You may have use of accessory muscles when they're breathing. They won't be able to lie flat. They'll have increased heart rate, anxiety, and decreased peak flow readings. A patient that's having an acute asthma attack will have the inability to speak in full sentences. So if you've ever heard somebody who's trying to talk after they ran a marathon, it kind of sounds like that. You just can't get the words out. You just can't breathe and talk at the same time. So how do we diagnose asthma? So the diagnosis and assessment of asthma includes a detailed patient history, pulmonary function test, chest x-ray, and pulse oximetry, and possibly ABGs. So the history, when you're gathering data from the patient, should include any childhood illnesses, family history of allergies or asthma, eczema, smoking history, and any exposure to like environmental triggers. So the patient should also provide information about how frequent they have these episodes, whether they were triggered by specific activity or time of day or time of year, like summer, spring, fall, or if it's more in the morning or evening, stuff like that. And then also we should be asking the patient, what did they do to feel better? What made them feel worse? Chest x-ray should be done, as sometimes needed to rule out other respiratory conditions that could mimic similar signs and symptoms. So here in the center of the slide, you see a peak flow meter. This is a handheld device that measures how well air moves out of the lungs. So during an asthma episode, the airways will narrow and constrict, and a peak flow meter can measure this narrowing hours, sometimes days before the patient even has an asthma symptom. So this can be really helpful in preventing a big acute asthma attack. So one of the most common and major tests of part of the pulmonary function testing is the FEV1, forced expiratory volume in 1 second. And for normal adults without asthma, it's 70% is the norm. So if you have a decrease in this FEV1 by 15 to 20%, then what's expected, then those patients are likely to have asthma. If those values improve after you give a bronchodilator by 12%, then it's diagnostic for asthma. So to put in perspective, you have a patient come in, they take this pulmonary function test, it shows that their FV1 is 50%. It's supposed to be 70%. So that's a 20% difference. So that's a clue that says, okay, you probably have asthma. If the patient is having an exacerbation or not, you can give a trial dose of a bronchodilator, do the test again, and if it improves by 12%, so it went from 50 to 62%, then we can confirm the patient has asthma. Okay, so that's what that means. When it comes to ABGs, so if a patient is having an asthma attack and it's early, so they just had the trigger and now they're having a hard time breathing, they're hyperventilating because they just can't get enough oxygen in their lungs. If you drew their blood and did an ABG, they're going to be in respiratory alkalosis. They're going to have low levels of carbon dioxide because they're hyperventilating and they keep breathing it all off. Okay, they're breathing it out. Once it becomes more severe, in a more severe asthma exacerbation or attack, then you'll eventually start having a really hard time breathing at all. So then you're going to be hanging on to carbon dioxide. So then you're going to be in respiratory acidosis. So you're going to have high levels of carbon dioxide. Now let's look at this asthma action plan. So this type of plan varies slightly from provider to provider, but this is the textbook example that they're giving you, so we're going to use this one. So this is really common in young kids who have asthma when they're at school, so that the school nurse and the parents know what to do if the patient or if the child starts to have an asthma attack. Okay, so if we look at this, we're looking at a green zone, yellow zone, and red zone. This is referring to the results of the peak flow meter reading. So the patient will find out what their baseline is, and then these little markers will mark the zones. So when the patient blows out into the peak flow meter, the small changes in that air amount, the air volume, will will determine which zone the patient is in. So if you're in the green zone and there's a little description here, you're not coughing, you're not wheezing, you're doing well, you don't need a short-acting beta antagonist. That is what SABA is. If you blow into the yellow zone, then your asthma is getting worse. These are some signs and symptoms you may have. You can do some activities, but not all of the activities you normally do. You have shortness of breath, etc., etc. So here you should take your SABA and your steroid. Red zone, again, this is full-blown asthma attack. You need your SABA and steroid. So it's pretty self-explanatory. You go through it. It's everybody that has asthma should have this type of action plans somewhere. Okay, so this is a overview of medications used to treat asthma. So you'll need to know that some are for rescue, some are long-term. So rescue meaning that when you're having an active asthma attack, these are the medications you're going to give. The long-term are medications that you take every day, routinely, not as needed, that will hopefully prevent an acute exacerbation from happening in the first place. So here we have our quick relief rescue medications. We have bronchodilators and anti-inflammatory medications. So the bronchodilators are short-acting, inhaled B2 agonists. Okay, this is like our albuterol, and we're going to call those SABAs. Okay, short-acting beta agonists, SABA. So if a patient's having an acute asthma attack, we're going to give a SABA. Then we have our long-term controller medications. So these are anti-inflammatory drugs and bronchodilators. So our anti-inflammatory drugs are inhaled or oral corticosteroids, and here are some examples. So you're not going to give this by itself, so during an acute asthma attack. Then we have bronchodilators down here. So we have long-acting, and methyloxanthines, which is thiophyllene. So that's a LABA. These bronchodilators are LABAs. And so just remember that LABAs can only be used when you combine them with inhaled corticosteroids. Okay, so these are LABAs, but they work in combination with these. So for example, you have a patient who was diagnosed with asthma. They're going to give them a LABA and tell them to take these 2 puffs every day. And if you have an acute asthma attack, then you're going to take this SABA. This is the guidelines used by most providers on step 1, step 2, and as the the severity, like if it's not controlled, then they need to add another medication and so on. And this is just a visual of the relievers, which are the ones you use during an asthma attack, controllers, combinations, and preventers. You don't need to know this. Okay, so complication of asthma is status asthmaticus. So this is when it just doesn't stop despite what you do. You're giving the medication, you're giving the anti-inflammatories, the steroids, bronchodilators, and just nothing is working. So these patients will require intubation. And you want to look out for this, and you're going to see bronchospasm, inflammation. It could lead to a mucus plugging where there's actually a big mucus plug in the airway. Chest tightness, wheezing, dry cough, shortness of breath, severe respiratory distress. You're going to see that pulse ox very, very low. This can be life-threatening, so this is going to be a priority patient. So assessment-wise, this is just a little bit of information for you here. Different levels of asthma. Mild intermittent, mild persistent, moderate persistent, severe persistent. So if you're having asthma attacks twice a week, that's considered uncontrolled because you really shouldn't be having asthma attacks that frequently, especially because we have triggers. So a lot of those triggers we can control, we can anticipate, and we have these medications that can be taken every day that can help prevent these episodes. So anybody who's having very frequent asthma attacks need to be reevaluated because that is uncontrolled asthma. So teaching wise, we want to make sure they have an individualized asthma action plan. We want to tell them avoid your triggers, okay, whatever those may be. We want to teach pursed lip breathing, medication regimen, inhaled medication usage. So they should know which is their quick acting versus their long acting. They should know how to use a peak flow meter and what those values mean in relation to their asthma action plan. They should not smoke. Any respiratory, people shouldn't smoke in general, but any kind of respiratory condition paired up with smoking is not good. It's just going to make things worse. So if they are smoking, they should stop. And then we want to educate them on when they should call the provider. Any worsening shortness of breath, cyanosis, blue around the mouth, they need to call or seek medical attention. And then they need to know how to use these devices. So there is an aero chamber or a spacer, that's what this is. And then we have our inhaler here. So when you use an inhaler, you're going to take off the cap, you're going to shake it up. Patients should breathe, exhale as much as they can, and then they're going to breathe in, push down on the inhaler, and try to hold your breath for a count of 10 so that medication has a chance to be absorbed. After that, slowly breathe out. So that's how you use an inhaler. Then we have a spacer. So this spacer is commonly used with kids, or you can use it for adults too that may have a hard time following these directions or being able to coordinate pushing down on this and then breathing in and then, this whole step process. This makes it a little easier. So this spacer has a one-way valve here, right here, and you put your mouth on it right here, just like the picture, and you put the inhaler in on this little side. There's a hole. The inhaler fits nice and snug. So the idea is that you push down on the inhaler and the medication stays in the chamber. So you put your 2 puffs in there, and then the patient puts their mouth here, one-way valve, and will take a big deep breath in, and they're able to get all of that medication without wasting it. Like sometimes when you do it this way, it comes out, or especially if it's a child, they didn't inhale at the right time, so a lot of the medication just stayed in the mouth. So that will prevent all this with this spacer. So when the patient is inhaling from this chamber, when they're taking out, sucking in that medication, they should do it slowly. They shouldn't, they shouldn't suck the air out so fast that it makes a noise, because that means that, they're doing it too fast. The medication, it's just not the way to do it. They should do it, take a big deep breath in, nice and slow. And then review box 26.2 in your textbook to give you more detailed step-by-step on how to use this MDI inhaler and the aero chamber. And then one more thing to note. When a patient is taking a medication, especially a corticosteroid, in an inhaler form, after they take their puffs and they hold their breath for 10 seconds and they breathe it out, they should rinse their mouth, because that corticosteroid is a medication. It can stay in the mouth. It can actually cause fungus growth because it is a steroid. It can also cause tooth decay. So we want to make sure patients are rinsing their mouth after using their inhaler. Next, we have chronic obstructive pulmonary disease, aka COPD. So first thing we see here is an umbrella. This is an umbrella term, and it refers to emphysema and chronic bronchitis. So the pathophys of this, there is airway limitation that is progressive and not fully reversible. So unlike asthma, this one cannot be reversed, and it is progressive. So important distinction there. Okay, and this is causing obstruction in their airways. So with emphysema, we are looking at the small airways, the alveoli. That's where the destruction is. For chronic bronchitis, we're looking at the bigger airways, the bronchioles. And that is going to be a cough, lots of sputum production that lasts at least 3 months in each episode of 2 consecutive years. Okay, so that is the diagnosis for chronic bronchitis. Let's move on. Okay. So risk factors, smoking. 80 to 90% of COPD deaths is related to smoking. So that is going to be a very big teaching point, is smoking cessation. Occupational dust and chemicals. So maybe you work around some kind of factory that has a lot of dust all the time and you're not wearing the appropriate protection, PPE, then you can develop COPD over time. Just really bad pollution. Some cities, some countries have really bad pollution. Those people can develop COPD when they're older. Secondhand smoke is also a contributing factor. And then some genetic deficiency of this alpha-1 antitrypsin or AAT can put you at risk for COPD, but that's less than 5% of people who are diagnosed with it. Okay, so let's look at the pathway here for both emphysema and chronic bronchitis. So emphysema, so you're going to have injury to the alveoli over time by your inhaled pollutant, whatever that may be. We're going to say cigarette smoke. So that's going to lead to loss of lung elasticity. So the lungs aren't going to be able to stretch out like they, not only stretch out, but come back to their normal form. Hyperinflation of the alveoli. So those alveoli are getting too big. This is going to collapse those little small airways prematurely, those little alveoli. That's going to lead to air trapping. That's going to lead to ineffective exchange of oxygen and carbon dioxide, which is not good. And then we're going to have non-oxygenated blood entering circulation. So these patients will be in a state of hypoxemia, and they'll also have elevated carbon dioxide. They're going to be retaining carbon dioxide. Then with chronic bronchitis, we're going to have the same thing, exposure to some type of inhaled pollutants. Again, we're going to say cigarette smoke. That's going to cause inflammation of the bronchi and bronchioles. The walls are going to thicken there. That's going to cause obstruction. There's going to be lots of increased production of mucus, also contributing to obstruction. So that is COPD. Emphysema, chronic bronchitis falls under COPD. Sometimes patients have more so emphysema, some have chronic bronchitis, some kind of have like a mixture of both, but both are considered COPD. So let's look at a normal lung versus a lung with COPD. This is just another visual so you guys can kind of get the picture. So on the left we have chronic bronchitis, and remember these are the large airways, so the bronchioles, and there's going to be a thickened wall and lots of secretions. Here they are, they're blocking the airway. Versus emphysema, where if you look here, there's loss of support, airway collapses, air is getting trapped in the lung, the elastic recoil is having problems with the little alveoli. Okay, so this is alveoli, small airway. This is bronchioles, big airway. Okay, loss of elasticity. And this one is going to be lots of mucus production and airway resistance. Okay, so COPD, clinical manifestations, increased work of breathing and shortness of breath. So when you picture a COPD patient, you're not always going to see a patient who cannot breathe on oxygen. Sometimes the patients will present in the doctor's office saying, you know, I used to be able to walk to the end of the block, and, you know, I'm kind of not able to do that anymore because I get short of breath. But maybe that's the only change that they've seen in their life. Okay, just that little change. I just can't really, I get short of breath. So it can be very, very mild changes, but you need to assess your patient, listen to your patient and say, you know what, let's run some other tests because that could be something brewing inside your lungs. Okay, so back to the signs and symptoms. Accessory muscle use, tripod position, a picture of that is right here. This position we tend to go in when we can't breathe. It kind of helps us to breathe. Increased AP diameter, which is a barrel chest, that is this picture here. Okay, you see it's kind of like a barrel. Cough, increased speed production, pursed lip breathing, all these things we're going to talk about as we go along. Skin color changes can be red or blue. Anxiety, that's from the hypoxia. SpO2 lower than 90%. Crackles and wheezes can be heard. Okay, so this slide shows you the blue bloater and the pink puffer, which will make more sense later. But right now I wanted to talk about what drives us to breathe. So for healthy people with healthy lungs and a healthy respiratory system, we breathe because we accumulate carbon dioxide. So if you hold your breath, you are slowly accumulating carbon dioxide, and your brain knows this, and it's going to force you to exhale that carbon dioxide out. So our drive to breathe is elevated carbon dioxide levels in our body. But for COPD patients, over time, their body has developed a tolerance to carbon dioxide because they are constantly, part of the disease is accumulating carbon dioxide. So their body over time kind of adjusts to that. So when their body is introduced to oxygen, it can actually have the opposite effect. So if you were to give a patient a lot of oxygen, even if it's like 4 liters on nasal cannula, if the patient has COPD, their brain might say, oh, look at all this oxygen we have. We don't need to breathe anymore. And literally they'll stop breathing. Respiratory function will just slow down and stop. So that's why it's really important that you ask your patient about their medical history. Are they on oxygen at home? Do they know what their normal baseline is? Okay, so let's talk about if a patient with COPD is having an exacerbation. So they tend to run a little bit lower than us when it comes to oxygen saturation. So normally we want us to stay above 95%, but with COPD patients, they have more leeway. So again, this really depends on the patient's baseline. Sometimes they saturate just fine, just like a normal healthy person, 95%. Maybe their normal is 92 or 93. Maybe their normal is 89%. It really just depends. So we need that information. That information is very important. But what if this patient who normally saturates at 90% now is having an exacerbation and they come into the hospital and they're satting at 87%? So that is too low. We have to give oxygen. We already know they have a risk of this situation that I just described, but they still need oxygen. So we're going to apply oxygen. We're just going to closely monitor it and keep it to the very, very minimum that the patient needs to stay up to their goal oxygen saturation rate. Okay, so make sure you don't give too much oxygen or else the patient will have a decreased respiratory effort and can stop breathing. So here's another visual for you, cartoon-wise. So let's talk about this blue bloater and pink puffer. So patients with emphysema, emphysema, sometimes have a reddish complexion and appear to be puffing when breathing. So that's why we refer to them as a pink puffer. On the other hand, patients that have chronic bronchitis are typically obese. They have hypoxemia and can appear cyanotic, so blue. So that's why we call them blue bloaters. Another visual for you for chronic bronchitis and emphysema. So patients can have both chronic bronchitis and emphysema, so their signs and symptoms, clinical manifestations will be kind of all over the place. But if the patient tends to have one or the other, you can kind of read through this and it kind of makes sense. Okay, so diagnosing COPD, we're going to get a history and physical, we're going to do some pulmonary function tests, we're going to do x-rays. Complications, this can lead to a spontaneous pneumothorax, right heart failure, and cor pulmonale. Okay, and we don't need to know the details on that. That's not the focus for us at this time. Okay, nursing interventions, we're going to give medications. There's definitely going to be bronchodilators ordered. Provide oxygen. Remember to be close, pay real close attention to how much you're providing. And provide small, frequent meals. If they're having an exacerbation and a hard time breathing, it can be really hard to eat and breathe and swallow. So sometimes patients will just opt not to eat, but we need adequate nutrition and calories so the body can heal itself. So we still want them to eat high calorie meals. Exacerbations, patients will be on inhaled bronchodilators. You should know what these medications do. So inhaled bronchodilators, just like it says, it's going to relax the bronchioles and open them up. Glucocorticoids are anti-inflammatory. Okay, anti-inflammatory. Antibiotics if there is an infection present. And sometimes these patients need a little extra help, so we can do non-invasive positive pressure ventilation, like a CPAP or a BiPAP can help kind of open up those airways. Inhaled medications, again, bronchodilators, beta agonists, anticholinergics, inhaled glucocorticoids. Teaching, we want to teach pursed lip breathing. There's a slide on the, there's directions on the next slide. Pacing of activities, so if they're feeling tired, they should rest. Smoking cessation, huge, 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 and here it is. So you'd be surprised how many people have COPD, full-blown COPD, but they just can't stop smoking, and it's just never going to get any better, no relief. We want to educate them on the medication regimen. They will be taking medication daily, long-term. Patients should get vaccinated. So the pneumococcal, the pneumonia vaccine, if they're over the age of 65, we need to encourage that. Also the flu vaccine. Even if these patients feel well, they still should get the flu vaccine and the pneumococcal vaccination. They should recognize symptoms of exacerbation, both the patient and the family, so that they can get early treatment. And then coping. So The patient and the family should be aware of the lifestyle changes that may occur because of COPD. They maybe won't be able to participate as much in activities. It may be hard to maintain an active lifestyle. Even the ability to care for themselves can lead to depression, social isolation. So you want to have a good conversation with the family and the patient. And then up here, this is from your textbook, smoking cessation. So medication, and the reason why we're emphasizing smoking cessation is because it is so important for any type of respiratory condition, but especially these that are directly a result from smoking, like COPD. Okay, so medication, first line, we're going to have nicotine replacement therapies. Then we have non-nicotinic medications. So we're going to try to give them a patch, gum, lozenges. A lot of these are over the counter. Second line will be clonidine and nortriptyline, not as common, but hey, if they're having a hard time, then we're going to try that. Behavioral counseling therapy and physical activity, if possible, if the patient is able to. Here is pursed lip breathing. So sit upright with the neck and shoulders relaxed. Inhale through the nose, counting slow, 1, 2. Exhale through pursed lips as if you were blowing out a candle, slowly, 1, 2, 3, 4. So controlled breathing, slowly in, slowly out. Your exhalation should actually be twice as long as the inhalation. And then you continue to do this until that shortness of breath is controlled. So pursed lip breathing can be pretty effective. So this is a table from your textbook 26.1. It compares emphysema, bronchitis, and asthma. So this is a really nice chart. I like it. Take a look through it. Next is cystic fibrosis. This is a genetic disease of the exocrine glands, and there is a deficiency in a protein that causes a disruption of iron transport, mucus buildup, and you ultimately will have respiratory, gastrointestinal, and reproductive complications because of all of this mucus that clogs all of these ducts and really affects normal processes of the body. So here we have it. It affects all of these things pictured here, but mostly the respiratory system. All of that extra mucus is going to plug the airways, causing obstruction. It's going to lead to inflammation, bronchiectasis, chronic infections, and leading cause of mortality. So this can cause early death. In the GI system, it mainly blocks the transport of pancreatic enzymes. So our pancreas has two functions, endocrine and exocrine. So the endocrine functions is insulin, and the exocrine functions are all those enzymes that we use to digest our food. So if those are blocked, we're going to have an issue. So that means the patients are going to have decreased breakdown and absorption of food, pancreatic endocrine insufficiency. So they can actually get cystic fibrosis related diabetes because of all of the blockages. The insulin just isn't able to make it out where it needs to go. Then we have our reproductive system. Unfortunately, plugging and deterioration of the vas deferens before birth will cause infertility in males. So clinical manifestations of cystic fibrosis. What you're going to see is going to be directly related to which organ systems are affected. And this is going to vary from patient to patient. So one cystic fibrosis patient may exhibit different signs and symptoms than the next person. So respiratory systems include increased work of breathing, which could be fast respiration, tachypnea, or irregular breathing patterns. The patient can be diaphoretic, so sweating, nasal flaring, pursed lip breathing, intercostal muscle retractions, and use of accessory muscles. Decreased exercise capacity, repeated lung infections. Now the GI system is largely affected because of the accumulation of mucus in the pancreas, which again, it makes the release of those pancreatic enzymes almost ineffective because they can't pass through that mucus. So clinical manifestations of that would be steatorrhea, which is foul-smelling, greasy stools, poor weight gain and growth, intestinal blockage, and severe constipation. So you should know these signs and symptoms. Okay? All right. So diagnosing cystic fibrosis, a sweat chloride test. So part of the genetic abnormality is the ions of chloride Chloride, remember, is best friends with sodium. So it actually shows that in our sweat for cystic fibrosis because that exchange is not normal. So testing the sweat, normal is less than 30. With cystic fibrosis, it'll be more than 60. And there is mandatory newborn screening in this country for cystic fibrosis. All right, so medications. So we know what the problem is. There's a lot of mucus clogging everything. So we want bronchodilators to open up those airways, mucolytics to break down all of those secretions. We can do inhaled hypertonic saline. Again, we're trying to get rid of those mucusy, thick mucus in there. Anti-inflammatories, antibiotics if they have infection, fat-soluble vitamins. The most recent addition to the pharmacological management of cystic fibrosis is the use of CFTR modulators. So these medications they target specific defects caused by the mutations in that CFTR gene, which is causing the cystic fibrosis. So these medications, they don't correct the errors in the gene, but they try to correct the malfunctioning of the protein made by the gene. So there have been some success in these medications, but because there are many different mutations, these aren't always very effective. So interventions and teaching. So we are talking about the airway, so that is our priority. We want to make sure that they know airway clearance techniques, such as postural drainage and percussion. So postural drainage is, you can take a look at that or listen to that recording. It's where you place the position in different positions in order to help drain certain areas of the lung that might have these issues. Diet and supplements. So these patients may experience a lot of weight loss and malnutrition because we're missing those pancreatic enzymes to help break down the food. So we want to increase their caloric and vitamin intake to increase energy and hopefully increase weight. We want to make sure these patients know and avoid risk factors of exacerbation and get genetic screening and counseling if they plan on having a family. And then here, because the airway must be clear of secretions to maintain patency, and this is part of our ABCs, chest percussion therapy, where we do percussion and postural drainage, this needs to be done on a daily basis for these patients because the mucus is continuously being produced, so that needs to be done every day. Okay, surgical intervention. These patients may need a lung transplant or a pancreas transplant. And now our last lower airway disorder, lung cancer. So lung cancer is the second most common cancer in both men and women in the US, and it's most prevalent in people over the age of 65. All right, so we know what cancer cells are. We know how they grow, where they come from. So the lungs are no different. There are two major types of lung cancer: non-small cell cancer, which represents about 85% of all lung cancers. And then we have small cell lung cancer. The 5-year survival rate for small cell lung cancer is only 5 to 10%. Okay, let's look at risk factors. So the major and most preventable risk factor for lung cancer is smoking, and the risk increases with the number of cigarettes smoked per day and the amount of time in years and smoking. So huge smoking cessation. Smoking is bad. Okay, other risk factors: secondhand smoke, radon, which is a carcinogenic, occupational pollutants, and asbestos. Okay, so here in this picture, again, I know we are all aware of what cancer is. Stage 1, tumor appears in the lung. Stage 2, it's now in the lymph nodes. Stage 3, it has traveled into the surrounding tissues. And stage 4 is metastasis to other organs. So signs and symptoms, they're going to be respiratory related. So a cough that doesn't go away, changes to a chronic cough that you've always had, hemoptysis, which is blood and sputum, shortness of breath, wheezing, hoarseness, chest pain, headache, Okay, if you have a headache with lung cancer, that usually signifies that the cancer has spread to the brain. If you have bone pain with lung cancer, it's usually because the cancer has spread to the bones. And then we have weight loss, which is often a common side effect or common clinical manifestation of any type of cancer that is advanced. Then we have diagnosis. So we can do imaging that is going to look for any abnormal tissue infiltrates, mass. It'll look for metastasis to the ribs or, the body in general. Sputum for cytology, that will look at specific tumor cells. Bronchoscopy or mediastinoscopy. So they're going to put in a camera, take a look around in there, maybe take a biopsy sample like that. Bone and abdominal scans. So really just checking out to see if there's anything abnormal related to the cancer. When it comes to management, non-surgical, remember these are our lungs. We have to be really careful because this is how we breathe. Surgery is the preferred treatment if there is no metastasis. So if there hasn't been any spreading to any other part of the body, then they will try to do surgery, and that's most common for non-small cell tumors. And surgery itself, you can see it just really depends on how much of the lung is affected and how much they will take out. So they can take out a little wedge, a segment, a lobe, or a whole lung. Patients will get a combination of chemo, radiation. There's going to be a lot of pain that comes with this, so we want to make sure our patients have pain, controlled pain. So your nursing interventions for lung cancer are going to be very similar to other respiratory conditions. We're going to provide oxygen to keep their saturations above 90%. We're going to give them any medication that's ordered, which will probably include pain medications, anti-anxiety meds. This will provide relief from both pain and anxiety, which will allow you to relax and to increase the expansion of the lungs. That will improve oxygenation and ultimately their quality of life. Also, bronchodilators that will open the airways and decrease the work of breathing. We want to provide small, frequent meals with supplements. We want to avoid excess pressure on the diaphragm when you have a big, large meal and your stomach is full. And then also supplements will increase the caloric intake for these patients and provide energy for all of that work of breathing. For positioning, semi-Fowlers is the best. That will increase oxygenation by allowing that full lung expansion. Then for teaching breathing techniques, so controlled breathing techniques will help to increase the clearance of sputum and will reduce the sense of breathlessness. And pursed lip breathing specifically will encourage the patient, encourages the exchange of oxygen and carbon dioxide. We want to educate on pacing activities to conserve energy, and I guess I need to talk slower. Pacing activities will conserve energy and will help to decrease, again, the work of breathing. Smoking cessation. Some people that have lung cancer are still smoking, so they need to stop it. They need to stop smoking. Nutrition. Again, small, frequent meals, high caloric intake. Medication, we talked about that, and pain control. We don't want to forget about pain, so make sure you're doing your pain assessments. And that concludes this chapter.